Hello everybody. I'd like to welcome you to Empire's program on facial aesthetics. As a brief introduction, I'd like to tell you a little bit about myself. I'm a retired surgeon who transitioned into aesthetic procedures and aesthetic surgery about 15 years ago and was the medical director, clinician, and owner of 7 full-service medical spas in the New York, New Jersey area. As a result of our spas, my experience includes injecting close to 6,000 vials of Botox, which equates into some 25,000 different treatments, 2,250 syringes of dermal fillers, including all levels of aesthetic treatment, including liposuction, laser-assisted lipolysis, which you may know as smart lipo, tattoo removal, CO2 resurfacing, and all the other services that are included in medical spa environment today, including mesotherapy, sclerotherapy, aesthetics, thread lifts, and more. I have experience as an associate professor at the Downstate Medical Center, Brooklyn, New York, and interim director at Kings County Hospital, Brooklyn, New York as well. I've been training with Empire for over 10 years now. As a matter of fact, last December was my 10th anniversary. I teach all of Empire's aesthetic medical courses. You're applied to Empire for aesthetic training. So that means you're probably taking additional courses or other courses that'll lead you to the end to be a competent aesthetic provider. As in all areas of medicine, it's important to know basically what you're treating, how to classify them, what the appropriate treatments might be for those conditions, and how to get exceptional results. So facial aesthetics is a good place to start. We'll be starting off by talking to you about skin classifications, conditions, and the appropriate basic treatments to improve or enhance their conditions to get great results. So there are so many different presentations, so many problems associated with aesthetic medicine. It's important to know or have a baseline of their physical characteristics, conditions, and level of damage that you're trying to repair. So when we're talking about those classifications, there are 3. Well, several, but basic 3 are the Fitzpatrick classifications, which shows a patient's or a person's ability to absorb or react with sun and the basic level of reaction that they have. These are the Fitzpatrick classifications. The Lances classification takes ethnicity into account when identifying and prescribing treatments for patients. And the Perkins classification is a classic baseline treatment for evaluation and classification of acne and acne treatments. There are so many different types of presentations around the world. It's important to know your basic patient's baselines before you initiate treatments. And this is important in all areas, but especially when it comes to the newer treatments that involve light energies like lasers and IPL treatments. The Fitzpatrick classification, if you're not aware of, was first defined by a dermatologist from La Jolla, California. His name was Dr. Patrick's. And this came as a result of the exposure of his patients to light and light energy from the topographical area that he resides, Southern California, and the condition of the skin as it related to laser treatments and other problems associated with care. His classification basically defines all people into 6 skin types from 1 to 6, starting from those who have or lack any pigmentation to those who have all pigmented skin, African American or Negro Black patients, and the variety of those classifications in between. From this slide, you can see that skin type 1 are those who always burn, never tan, and easily burn and turn red in the sun. It progresses to those who always burn but tan minimally, those who burn moderately and gradually tan. This is skin type 3. I need to be aware that this is the midline of the Caucasian population. Most Caucasians fall into this area. Moderately brown patients who burn minimally and tan well, they might be considered Mediterranean or Mideast. Those who are darker brown, who rarely burn and tan profusely, may be considered from those more towards the Indian continent or Caribbean personnel. And then those who are mostly black colored skin, those patients never burn, and have deep pigmentations, so tanning isn't an incidence here. Fitzpatrick classification is evaluated by or scored by a series of questions. Each question has a category including genetic predisposition, reaction to sun and exposure, and tanning habits. Each one of these questions in the area have a score of 0 to 4. Each area has a total score composition that can be from 0 to 16 with 4 questions, or 0 to 8 in the tanning habits. And they progress from those who never tan, never go in the sun, always get red. The total score of all 3 components, of all 3 categories, that can be basically from 0 all the way up to 38 or 40 in that area, will define what skin type you have, with a score of 0 to 7 putting you type 1, meaning you have essentially no evidence of melanocytes, you have blonde or red hair, you have blue eyes, freckle skin, and very, very little melanin. These are the patients who burn all the time, can't stay in the sun, and never tan. And it progresses up to minimally tan, moderately tan, and to the Fitzpatrick types 4, 5, and 6 that have significant amount of melanin, that tan easily and very rarely burn. The score gives the Fitzpatrick skin type. It's the Fitzpatrick skin types that's used to determine your ability to have treatment in areas for certain conditions, such as laser treatment for skin resurfacing and hair removal, etc. The Lancet ethnicity score is a very simple classification system. It typically takes a look at ancestry and the hereditary predisposition. It was introduced recently in 1998, and basically states that no matter what your tanning habits are, no matter what your overall skin color is, or no matter what your exposure is, any person who has an Asian, Native American, Middle East, or Latin American predisposition, also patients who have Mideast and Mediterranean heredity, should be considered 1 Fitzpatrick type higher than they present, or at a minimum of a Fitzpatrick type 5. And these are the starting points, so that when evaluating patients, as you'll find out from additional treatments, that it's important in order not to have or to cause any damage to the skin based on melanin production in the skin. And again, we talked about laser treatments, you should be aware of that. These are Lance's ethnicities, Fitzpatrick's 5, not so much so that they look like they have melanin in the skin, but from their hereditary background, they will tend to have melanin in the skin that will react to light more than those patients outside this ethnic group. Specifically the Asian population, and I'm not sure whether the Asian population is included in the Lancer ethnicity scale. Specifically the Asian population have skin that appears more Caucasian, darker on, lighter on the Fitzpatrick scale, but they maintain or contain melanin in the skin that reacts as if they're a deeper or darker skin type, so that an Asian population, when exposed to the skin, will react and get more tanned or more reaction to sun than somebody outside that ethnic group, and it flows over to Native Americans, Latin Americans, Mideasterns, and Mediterranean as well. So they don't actually look like they have a darker Fitzpatrick type, but indeed the melanin in the skin from hereditary have them present with treatments as well. And here's in Fitzpatrick 6 in a Lance's ethnicity scale. Now this young lady, or these young ladies, show that they appear darker than the previous slides, so these would be Fitzpatrick's 5s and 6. Burton's classification deals specifically with acne and acne classifications. It runs between grades 0 to 6 and can be modulated in between. Grade 0 is the absence or total absence of acne. Grade 1 would be subacute acne with barely visible comedones. Grade 2, acne is slightly inflamed. Grade 3 is mildly inflamed acne with papules and the beginning of some redness and erythema. The grading can be defined as those who have no clear acne, clear skin, no inflammation, almost clear skin for type 1, mild to severe. Progression from grade 1 would be grade 2, and then moderate severity would be grade 3. Grade 4 has moderate, containing many inflamed papules. Grade 5 has nodular components, and grade 6 have cystic components. And these are the end stage. These lead, the cystic lesions lead to nodules and diffuse scarring. There are alternate classifications into mild, moderate, and severe, and these are general observation classifications, not more specific classifications as in the Burton's classification. Here are some photographs showing the presentations of the different types of acne and progression. The photograph on the left shows a mild to moderate acne, which would make it a Burton 3, few papules and pustules, no nodules. The next one is moderate severe acne, which has 7 papules and several nodules. That would be a Burton's 4. And a Burton's 5 is shown at the right side, which has nodules and papules and pustules together. The progression can be from different conditions, from none, mild, into severe, and this is the subjective classification. Before we move on into skin definition and histology of the skin, I'd like to give you just a little bit of information on the pathophysiology of acne and how acne happens. Like many conditions of the skin, it's caused by the effect of testosterone on the pilosebaceous unit, not the actual amount of testosterone, which leads to increased sebum production and also a decrease in the lumen of the ducts that process the sebum out through the skin. This leaves an increased time of transmission, which can cause bacterial seeding, which leads to the process of comedotins and inflammation, papules, and pustules. It's a simple explanation. There's much more to it, but it basically starts by the effect of testosterone on the pilosebaceous unit that hypertrophies the gland, hypertrophies the unit, increases secretion, decreases transmission, that leads to inflammation from bacterial seeding. It's the basic concept of the association of testosterone and the production of acne. Also be aware that everybody gets acne sooner or later. It usually occurs in your peripubic area when you change from your prepubic to postpubic hormonal levels, male or females. That change typically drives an acute limited production and change in your skin and production of sebum, which leads to acne in everybody. Everybody gets it. Many people don't realize they have it, maybe just transient over several weeks. But then some people have such clinical, subclinical presentations that they don't even have a presentation. But it's this transmission of the body from prepubic to propubic, postpubic, with the changes in your hormonal levels that leads to acne. Almost always starts on the forehead, progresses down the face and to the chin, and then can go around the back into the back, upper and lower back. That's when it becomes quite severe and requires systemic treatments as well. So those are our classifications, and in all specialties, in all levels of care, and all treatments, before you treat a patient for any condition, you need to know what you're treating and classify it. So this will help you to get a baseline of many of the conditions that you're going to be seeing in your new aesthetic venture. So bringing back a little bit of histology, let's talk about the anatomy, histology, and physiology of the skin and the aging effects. In general, the skin tends to age at a rate of reduction in its skin components, collagen, fibrogen, and elastin, a reduction about 1% a year for every one of your chronological years. So the collagen, hyaluronic acid, fibrogen, and elastin being produced in your skin typically is half as much as when you're 50 years old than when you were prepubic, and that tends to lead to migration, loss of support, sagging of the skin, damage that causes shifting and presents with the aging process, the change from a narrower lower face to a triangular lower face, as you can see in this slide. The aging process also is accompanied by exposure damage, typically to ultraviolet light, the #1 cause of damage to the skin, and the #1 cause of cancers to the skin as well. Obviously, this isn't a progression of one gentleman over time, multiple gentlemen with the progression planted. And you can see the damages associated with UV are hyperpigmentations, hypervascularization, and rhytid formation, with some evidence of volume deficit as well. So aging process of the skin is caused by UV damage in general and presents with hyperpigmentation, rhytids, and volume loss. So what are we looking for in the skin? Basically, we're looking for smooth, even colors without any wrinkles, that's supple and hydrated, to represent a more youthful appearance, a more younger age group. Also, as we're talking about the aging process, you have loss of production of the components of the skin, and also loss of support from systems around the skin, including fascial sheaths supplying muscles and ligaments that's suspended in place. This is all part of the aging process. What is the skin? Well, the skin composed 70% water, 25% proteins, 2% lipids, 2% carbohydrates, and 1% trace mineral elements like magnesium, sodium, etc. But mostly water. So when we talk about skin care, the first thing any dermatologist or aesthetic physician or esthetician will tell you is to remain, hydrate, increases and maintains your tonicity in the skin as well. The skin is composed of 3 layers. It's composed of the epidermis, the dermis, and the subdermal fat pad. That's the 3 layers that composes the organ of the skin. The skin is a physiological and anatomical separate organ. The epidermis is the outermost layer, contains 5 specific divisions. That's rest on top of the dermis, which has 2 layers, the papillary layer and the deeper layer called the reticular dermis, and that rests on top of the subdermal fat pad, which is on top of the superficial fascia. And these are the basic components of the skin. New epidermis forms in about every 30 days. Normally exfoliates on a daily basis. You see exfoliation daily. If you would just scratch your skin, any of that flaking tissue is the upper layer of the skin exfoliating. It can be done normally, or it can be accelerated using peels or microdermabrasions, which will be addressed a little bit later in this program. A normal exfoliation process for the epidermis also starts as the top layer, or the most superficial layer, exfoliates. The layer underneath it replaces it, and they deposit another growth layer underneath. So it's constantly exfoliating and depositing from the bottom up. That's a replacement level that you need to be aware of, because treatments for improving skin presentation with peels and dermabrasions take off the upper layer to expose a more basic layer that gives a younger, smoother appearance. The 5 layers of the epidermis include the stratum corneum, lucidium, granulosum, spinosum, and basalis. And again, they all come from a more basic layer of the 5, and they migrate up and change into their initiation, which is the basalis, and convert into the stratum corneum. As we mentioned, the stratum corneum regenerates every 30 to 45 days, and it's highly keratinized, which makes it very stiff and dense, and it's non-vascularized as well. The outermost layer of the epidermis is the stratum corneum. It's made up of keratinized cells, it's non-vascularized, and it's the barrier between water diffusion out of the body and absorption of foreign bodies into the skin that can be damaging to your health. This is the outermost layer, and it's a barrier for lipid solutions as well. Can be between 5 and 50 cell layers thick. The secondmost layer is the stratum granulosum. It's underneath the stratum corneum, and are dead cells that are no longer viable. This is now where they start losing their nucleus. They become keratinized, which makes them thick and protective. They are not vascularized as well, and this is the name taken from the pre-keratinized material that's included in the cell. Here is a slide that demonstrates facial anatomy to a degree. It's something that you should be able to be aware of, so that when you're evaluating patients and treatments, you'll know which parts of the face are more sensitive or thin, and which parts of the face are thicker and can absorb more treatment or may need more treatment for correction and repair. This slide represents the thickness that are presented here on the diagram, with the chin being the thickest area of the skin, measuring 2.5 millimeters thick, with the eyelids being the most thin area, and that's both the upper and lower eyelids typically 0.5 millimeters thick, very sensitive area. Anytime you're treating around the eyes, you need to be aware of how thin the area is, and have to treat outside of the orbit because of the thin material. You don't want to make any treatments become an interorbital component, which may damage the skin and the globe as well. And the rest of the face is defined by thickness as well. Not something that you need to memorize, but something you need to be aware of, and knowing that when you're talking about the chin, you're going to go to the forehead, then you're going to go back down to the eyes as being the thinnest, with everything else in between. An important concept. This basically lets you know the availability and the length and the depth of treatments you're going to be performing, like peels or microdermabrasions, in order to prevent any damage or harm to the patient. The aging skin tends to react by getting thicker, which decreases the oxygen content to the upper layers and allows more nutrients through. So the epidermis is the protective layer, protective area, 5 layers thick, perpetually desquamates, replaced from below by being moving up the progression sail, so the basalis layer eventually becomes the stratum corneal layer, and that rests on top of the dermis. Now the dermis is the powerhouse of the skin. That's where all of the processes occur. That's where all the organelles reside. And that's where all the activity that the skin involves in your health also reside. Complex systems of fibers that contain collagen, fibrogen, elastin, hyaluronic acid. It supplies blood to the epidermis, although the epidermis has no specific blood vessels. What feeds the epidermis are a network of dovetail vessels that go into the epidermis that supply the dermis up to the layers that are vascularized, and then those skin cells convert into non-vascularized cells like the stratum corneum, stratum lucidium, where they become keratinized and desquamate. And the dermis, as we mentioned, is divided into 2 levels: the papillary dermis, which is the more superficial, and the reticular level, which is deeper. If the dermis is considered the powerhouse of the skin, the reticular dermis is considered the powerhouse of the dermis, the deeper component that has most of the organelles necessary for function of the skin. We mentioned about the dovetail component of vessels into the epidermis from the dermis that gives it its vasculature. The most important structural feature of the dermis is a network of proteins that consist of collagen, fibrogen, elastin that supports the skin, and they're embedded into a gel-like substance called hyaluronic acid. The papillary upper dermis is a highly vascularized area that contains nutrients, and it's used to regulate temperature. Here's an old pearl that I learned when I was in the Army. Actually, it was taught to me by my father, who spent 5 years in the Army. If you're in a situation where you have high heat and humidity, the best way to cool down in that situation is to take a hot shower. And the reason why you'd want to do that is that hot shower will tend to open up the vessels in your skin, the vasculature in your skin, and by opening up that highly vascularized area, will regulate your temperature by letting heat out of your skin. And even though it's hot outside, the change in temperatures and that high vascularization will have you lose heat, and you will proportionately feel cooler. Just a little pearl that you come across that you might find interesting. And the area for collagen reproduction resides here in the papillary dermis. It's called the gransome. The reticular dermis, as we talked about, is the powerhouse of the dermis. It contains follicles, glands, and ducts, muscles that are necessary for function. It provides structure and elasticity of the skin, and it's the deep reticular dermis that we're talking about. The aging process can be categorized into 3 distinct subgroups: 1, 2, and 3. Type 1 is the appearance, the early appearance of vascular and pigmentation changes. These are patients who will come in with fine microvessels or some superficial telangiectasias of the nose and anterior face, associated with the beginning of sunspots, age spots, or liver spots, hyperpigmentation. Type 2 in the aging process now has those basic hyperpigmentation, hypervascular lesions, association with the presentation, the beginning of rhytids, typically occur in the lateral canthal area, but then may progress around the lips, cheeks, and chin. And type 3 is the progression with loss of support from tissues underneath the skin, loss of support within the skin, loss of collagen, fibrogen, elastin, weakening of tissues and fascial planes, And that creates volume deficits, folds, in other facial areas going forward. It's aging process divided into stage 1, 2, and 3. Hyperpigmentation basically is increase in pigmentation in parts of the body. Most common causes UV damage, and they're called by several names. They can be called sunspots, liver spots, age spots, solar lentigo or lentogens. In the processing and treatment of these problems, you can use microneedle and other protocols. This slide shows the possible depth for treatments for different conditions. Acne scarring, as we talked about, acne calcifications would be treated at a rate of 0.5 to 1 millimeters in depth. Pigmentation changes in the same. Aging and wrinkles still at 0.5 to 1 millimeter in depth. So this chart will help you identify the depth of treatment with microneedling or penning with products like PRP. Let's talk a little bit about penning and rollers. They both are adequate for treatment with and without products. Micro rollers are used in all areas of the face except around the eyes because of the decrease in the thickness of the eye. Also used in the décolleté and around the thighs for cellulite. The benefits are that they can use large areas with bigger rollers. The treatment time is much faster. However, the downside is that rollers only come in one depth and one size, and they're disposable. You can't even treat the patient after one treatment for a second treatment. They're one-time use only, and some rollers will cause a increased deficit in the skin, which may be beneficial depending on what products you're using and what treatment you're applying. Microneedling are used for similar placement and treatments by either interrupting the dermis, epidermis, and subfascial area or applying products like PRP into the skin. Microneedling has adjustable depths and speeds so that you can use the pen for more than one treatment in a treatment session. However, the heads are very small, so it takes much more time to do the same area. And even though they are adjustable in speed, the size difference can be significantly slower. And also need to be aware that the FDA is thinking about reevaluating its approval for these pens because of the possibility of cross-contamination. These pens can't be sterilized, soaked, or autoclaved. So they've shown that there's cross-contamination with blood or possible cross-contamination with blood that's splashed up on the handle that was not removed with typical alcohol cleansing. Many manufacturers are considering taking these interchangeable heads and putting condom sheets on the plastic sheets to prevent them from contaminating the handle. So as we mentioned with microneedling, these are penetrations into the skin at variable depths because they can be adjusted on the handpiece. And microneedling can be done independently of any other treatment just to insert those needles into the skin, cause damage, interrupt any fibrous or connective changes, and replenish collagen in the skin by direct damage. Or it can be used in conjunction with other treatments like PRP, which also has a video presence on our website. And these together also enhances the collagen, fibrogen, and elastin in the skin, giving a robust response and increased tone and tonicity of the skin. So let's take a moment to view this video on microneedling presented by Cosmopen, which will show the device and various treatment protocols associated with microneedling in the skin. As in dermal rollers, common areas of treatment for microneedling include all areas of the face, including the eyes, décolleté, and thighs for cellulite, but you can include the eyes with microneedling because you can adjust these, the depth of these injections to such a level as it will not interrupt or go deeper than the thickness of the eyes. Remember, they're the thinnest areas of treatment on the face. Special care to stay outside the orbit and not to damage anything intraglobally. We mentioned the differences between the two, including the size of the rollers and the mechanical automated up and down injections. But either way, they work very well for treatment of surface damage, volume deficit, rhytid, scarring, etc. So why does microneedling work? Well, it works much in the same way that light energy devices that do remodeling of the skin work. It's by damaging the skin to a level that causes it to regenerate and repair itself one by light energy, the other one by mechanical interruption. Each one of them damages the surface of the skin, causing the body to recognize the damage and send its immune system there to repair it. One with light, one without. Interesting point that you need to be aware of. Newer models of lasers being introduced by major manufacturers today are combining the mechanical interruption of the skin with microneedling attached to light energy to increase the manifestation of the results, and they're getting excellent improvement. It's something to be aware of going forward. Combination light energy and microneedling both do the same, get the same results with different techniques. Combining them, they're getting an enhanced repair. Here are some photographs showing the results of needling and roller treatments. And these are basic treatments that do not have, or at least are not defined with any adjuvant treatments like PRP, but you can see the improvement of acne scarring, wrinkles, and rhytids around the face. Again, microneedling works well alone or with other products. Microneedling can also be performed in combination with other treatments. We've mentioned laser energy before. Can also be performed with PRP treatments and with chemical peels, which will be a major component of this module today in facial aesthetics. Another significant aesthetic treatment should be associated with your aesthetic practice or medical spa is microdermabrasion. Everybody here should be familiar with microdermabrasion. Microdermabrasion is basically sandblasting the skin so that it removes the most superficial areas, the stratum corneum, prior to having it exfoliate, releasing that dead skin and exposing the more premature, smoother skin underneath the stratum lucidium. And this is done with a calibrated instrument under experienced hands. Microdermabrasions are well known, enjoy worldwide acceptance, non-invasive, as little or no downtimes. Basically, people do this with lunchtime treatments. They're perceived as natural and chemical free to a degree, and we'll talk about that difference in later slides. Immediate effect is apparent on the patients. Available in physicians' offices or in salons, spas, etc. So that gives it its worldwide acceptance, and it's going to be used on all Fitzpatrick skin types and any ethnicity in skin. Relatively affordable, and they are cost effective. They do what they're supposed to do, and they're very effective in their treatments. So how does microdermabrasions work? We mentioned it's sandblasting of the skin. The apparatus, depending on the type, and we'll talk about the three different types, runs across the skin, and either by suctioning a exfoliant onto the skin or manually exfoliating it with brushes or diamond tips, takes the skin surface down through the stratum corneum and sucks it away out of the system. It also is able, through certain systems, to increase lymph flow and remove extracellular fluid from the area, increases drainage, exfoliates several layers of the stratum corneum. The vacuum will also stimulate blood flow, clean out pores, and remove debris from the upper surface. And the settings and flow are operator dependent, so the results are an operator dependent system. When you're using a crystal-based system, low practice settings apply low force, high vacuum settings apply high force, and the pressure alone and the medium work together to renew the skin. We'll talk a little bit about exfoliation treatments now. It was the second most popular non-surgical, non-ablative aesthetic treatment in 2013, and it continues to increase in popularity. Always has been well accepted, as we mentioned. According to the ASAPS, there's more than 5 million patients that use microdermabrasion every year. But if you're considering patients as treatments, many of these patients use multiple treatments. Some use them serially every 6 to 12 weeks to maintain the improvement associated with it. This is basically keeping your skin exfoliated to a younger presentation. And they're non-invasive, so they're accepted by all age groups. It's classified as a type 1 device by the FDA. There are no specific standards, and it's been given an exempt status as well by the FDA. So the demand is driven by multiple venues. Because of its availability, estheticians, nurses, and physicians can perform them in different localities. Here's a histogram or a histological slide of skin through the microdermabrasion process and peeling process. And you can see from a baseline, which has disorganized surface presentation and cell types, becomes more organized, more nucleated cells on the surface that even improve with micropeeling secondary to microdermabrasion. These are important slides because it defines the two basic types of systems that are in use today. There is a third. However, the third is falling out of favor so significantly that it's not even readily available in the United States, and that would be the Bristol tip system. The reason why the Bristol tip system is not universally accepted is because it's not perceived as being clean or sterile. The hair brushes or hair fibers, no matter how they're cleaned, either manually or soaking, sometimes maintain cellular debris from the previous patients, which can lead to cross-contamination. So the two main systems that are in use today are the crystal tip system and the diamond tip system. The crystal tip system uses a crystal powder that's vacuumed up against the skin under pressure. Then that powder will exfoliate the upper layers of the stratum corneum, as we talked about, and the vacuum will pull that away with the dead exfoliated cells. Diamond tip systems don't have powder associated with it. It uses commercial level diamonds that are implanted in steel heads with different degrees of diamonds to give different degrees of coarseness or fine tuning to those heads. And this has become the more accepted of the two, even though crystal tip systems have been the most universally used. And the reason why there may be a change now is these powders, when they're planted on the skin and stimulate the exfoliation, can be perceived as being entered into the environment, inhaled by the patient, and have secondary complication effects. So with that reason, there's a trend now to diamond tip systems, but crystal tip systems still remain the first in popularity. Also need to be aware that these crystal tip systems are proprietary, so any apparatus necessary to use them, including canisters that contain the product being vacuumed onto the skin, has to come from the manufacturer. They can't be reused. And tubing and disposable heads and tips also. So unless you choose a reasonable manufacturer, you can be spending a lot of money on supplies and disposables. These products can be purchased new or used, and you need to look for medical grade treatments, not something that are used in home environments. Okay, so let's talk a little bit about the protocols used with microdermabrasions. And another pointer here that essentially microdermabrasions are part of a training program that all estheticians must complete prior to their certifications as an esthetician, so that in my spa, at least, as a practicing physician and surgeon, most of my microdermabrasions and peels were performed by my estheticians. They need to have 500 hours of training in an aesthetic program to obtain their aesthetic license and degree. So the first thing obviously you're going to do is you're going to remove makeup and cleanse and degrease the skin, thoroughly dry it, and go into a phase of treatment 1, 2, and 3. These are light linear, light circular, and then a combination of the both until the ultimate endpoint is mild erythema. Rinse the skin, and then apply some soothing lotion. In our spas, our estheticians use an aloe cream as a post-treatment moisturizer, and it worked very, very well. And in today's day and age, nobody should be going to a tanning booth, and everybody should be protected with a sunscreen minimum SPF of 30 all the time. And the phases that we're talking about are the light linear phases in order to degenerate some circulation and remove the upper layers. And then the second ones will be a circular sweeping motion with a little bit deeper pressure. Some people put in a square pattern as well. And the third is to combine the two with a deeper pressure to have deeper abrasion until the skin is moderately erythemic. Here's a diagram or presentation of a crystal-based microdermabrasion system. You can see the product applied under vacuum on one arm and then taken away with vacuum pressure on the other arm. The crystals are vacuumed across the dermis. They're not blown on, but vacuumed up and across. The subsequent dermis is exfoliated or peeled away. Pulls blood up to the skin, and it moves extracellular fluid out of the area. Also dilates and cleans surface pores, removing debris and bacteria, and also has an alternative cleanup for the epidermis. With the crystal-based systems, corundum powder, known as the second hardest object known on Earth, is an excellent abrading material and is the baseline of the powders that are used in the crystal-based systems. Inert, no chemical interaction, no systemic absorption. However, there has been some concern about respiratory inhalation, so it's lost its edge as being a non-chemical, non-invasive procedure. And the prices vary from different areas, from side to side, but typically a microdermabrasion will cost somewhere between $75 and $150 depending on your experience and the local market share. All of these products that are used in crystal-based systems are classified as free of all impurities, so that makes them safe to use as far as causing a cross-contamination. Are they sterile? Well, none of these procedures are sterile. They should be considered clean. Sterility involves prepping a field and plating a betadine with sterile sheets and dressings around it. The skin must be dry when you're performing the procedures, but they're not really sterile, they're clean. They have an germicidal effect, and they extract oil and debris from the skin and from the glands and ducts. Prices for a good quality, medical grade microdermabrasion crystal-based system, typically United States manufacturers are from $2,500 to thousands of dollars. It can be up to 6 or 7. You can purchase them over Alibaba's website for less. You need to be concerned about quality of the equipment and FDA 501(k) clearance, not approval. Here are some of the other sites available for access to crystal-based systems. And you can see that Alibaba is one, also available on eBay. There are many, many more sites, and there are some sites devoted directly to used microdermabrasion equipment as well. Diamond tip microdermabrasions, as I mentioned, perform the same process without any foreign body. These are commercial fine diamonds placed in steel bases with different degrees of coarseness or fineness associated with them. And they do the same thing as the crystal base. Instead of altering or monitoring the pressure and the strokes, the depth of the strokes and the pressure of the strokes, you do that all with the diamond manual or mechanical abrasion and pressure and length and depth. They're the diamonds, as we know, hardest substance known to man, and they're a girl's best friend, and an excellent abrading tool. Chemically inert, no interaction, sterile. They can be autoclaved. This is one of the benefits above the brush systems, because the products that are absorbed or exfoliated can be cleaned and sterilized in an autoclave system. Brushes, no matter what you do, even if you soak them and sterilize them, the product still remained on the brush. And they are controlled and predictable because the diamond tips work on the dependence of their coarseness. The operator dependent then is just limited to the strokes. Here are some diamond tip systems, and they're available in a similar mechanism and organizations. Typically in a diamond tip system, you're looking for a minimum of 7 tips from fine to coarse. You can go extra fine or extra coarse depending on your experience and your demand. There's a new variation of microdermabrasion, and it's called the hydrofacial, which includes a microdermabrasion cleansing system that also adds products that can be placed onto the skin and absorbed into the skin, such as antioxidants, hydration tissues. Treatment is non-invasive and non-irritating, improves the appearance of fine lines by adding hydration and products that improve the skin color and turgidity. One of the limitations you need to be aware of is the disposables with this product need to be purchased from the manufacturers, and only from the manufacturers. They can't use any other. This machine is designed for that. So disposables can be quite expensive, which raises the price of treatments for you. And also, the machine itself runs in the mid $20,000 range. I remember it being 21 to 23. People have told me now it's somewhere between 26 and 29. So it'll be yours to evaluate, but again, it does a good job with those limitations. Here are some slides that shows the results of a hydrofacial, which is microdermabrasion, and application of different solutions. After 4 treatments, a nice result. This is done in the lateral neck in a young gentleman with some irritation after 1 treatment. All right, so in all, in technique involved with microdermabrasions, these are highly operator-dependent treatments that involves knowledge of handheld movements, speed, depth, length, and direction of the strokes are all important. I'm telling you this from my personal experience, and it'll be up to you to decide how you want to handle it in your spa. But remember, all of your medical spa or aesthetic medical treatments should at one point have the benefit of an aesthetic provider in your area and licensed esthetician. And when they are available, this is what they do, this is what they're trained to do, which is what they do best. And as a provider or physician, there are other treatments that they can't do that may be even more beneficial and more profitable to you by performing them instead of microdermabrasions. And remember, these are operator dependent, 500 hours in order to get an approval for certification and for an aesthetic license and certificate. So, not saying not to do them, but after you learn the basics, you might want to defer these to estheticians. They do a much better job. They did a much better job than I ever did on them, and I conceded because they were well trained, and many of them have been doing them for years. Here are some before and afters of microdermabrasion showing release of hyperpigmentation and decrease in horizontal rhytids of the forehead, as well as a similar result after 6 treatments around the mouth and oral area and chin using a crystal tip system. Post-care instructions after microdermabrasion, as we spoke about earlier, everybody should be protected every day with at least a 30 SPF screen. Immediately after, you want to avoid sunlight for 3 to 5 days, and intense sunlight without protection forever. And it's best to avoid makeup or treatment for 24 to 48 hours after the treatment to allow the skin to recover. Although it's not an absolute contraindication. Mineral-based products like Jane Iredale, when applied after these treatments, are non-irritating. Patients tend to tolerate them well, and it doesn't alter the outcome of the microdermabrasion. So that would be an alternate to abstaining from medication for 24 to 48 hours. The next topic in this module on facial aesthetics deals with medical-grade chemical peels. Chemical peels are an important process in any medical aesthetic practice at any level, and are an important component to add to the results of any of your treatments. And as we mentioned earlier, can be combined with other treatments like microdermabrasion and PRP and microneedling to enhance its results. An important point to be aware of when you're talking about chemical peels, some of the more caustic or deeper peels have a high potential for problems and adverse events, so they should be dealt with very, very, very carefully and only applied once you have training and knowledge of their toxic values. And this is another area where you can become very proficient in these peels, do them effectively, but in actuality, in practice, you may want to defer these to estheticians because, again, estheticians require another 500 hours, or minimum of 500 hours in dermal peels in order to obtain their license as an aesthetic provider, and it'll take me forever to learn how to do them at that level. So it'll be up to you to decide how you want to handle them in your practice location. When we're talking about chemical peels, we're talking about 3 factors to consider, and that's acidity or pH, toxicity or safety under different concentrations and different products used for peels, and the metabolic process or the action and how it works. Classifications of peels, very, very, very important to understand because the classification will determine the strength and or depth of the peel, which will also be in association with its potential toxic effects. The most superficial of peels are the topical peels or creams that are placed on the skin to obtain a result. After that, there are superficial peels that go into the epidermis. Then after that is the mid-level peels that go below the epidermis into the upper dermis, and the deeper peels that have higher concentrations of caustic material that goes deep into the dermis, approaching the reticular dermis. And here's a slide that demonstrates that. You can see up in the left-hand corner the legend of the slide with yellow being superficial, and you can see that it goes down into half, if not most, of the epidermis. The medium depth peels go through the epidermis into the papillary dermis, and the deeper peels go through the papillary dermis into and approximating the reticular dermis. And each one of these have its own agents for treatment, its own reaction, and its improvement. Obviously, deeper peels giving overall better results, deeper peels being used for more advanced problems or damage to the skin. So what does a peel do? Well, it makes the epidermis more porous, able to absorb more nutrients, reduces fine lines, causes a smoother skin, promotes remodeling through increased collagen and interruption, eliminates or decreases pigmentations, reduces scarring, rejuvenates skin to be softer and more supple, and also eliminates hyperpigmentations and melanin content. The topical peels that are available in the United States are those in the retinoic acid, part of the terrapin family of organic acids, and it is vitamin A. Retinol is the #1 retinolic acid. Most commonly used are all trans retinolic acid. Tretinoin is the most used topical in the United States. Comes in concentrations of 0.05 to 0.1%, and that concentration depends on whether or not this should be available. It can be used over the counter or require prescription, a physician prescription, provider prescription to obtain it. And this is going to be important when we talk a little bit later about cosmeceuticals and presentation of products in your spa. So retinoic acid, retin A, tretinoin is the gold standard for a topical peel. It can be used for additional revenue, but does not highly increase your revenue. Used to satisfy your patient and give service to your patient for treatment with other conditions. It can be treated over the counter and can be provided by a provider depending on its concentration. And it causes a upper epidermal desquamation or peeling. Basically, it's almost like a microdermabrasion. It's used in acne treatment because it can open up pores, and it's used for pre and post preparation for other peels. Comes in a cream or a gel, and it thins the stratum corneum by a light exfoliation, nothing more. And also by irritation can stimulate keratin production. Here are some photograph representations of topical peel application before and after. And you can see no significant increase in deficits, but the topical appearance of the skin is markedly improved with the reduction or elimination of fine rhytids, elimination of hyperpigmentation, and cleansing of pores. From the topical peels, the next layer we talked about earlier was the superficial peels. These are the peels that go down to the epidermis and papillary dermis, and we combine them into superficial and medium peels because of the variations of depth. The most common type of peel is an alpha hydroxy acid peel, and the most common type of alpha hydroxy acid peel is a glycolic and lactic acid peels. They're weak acids unless they're used in stronger concentrations, which lowers their pH. The alpha hydroxy peels are divided also into medical and non-medical grade. Any concentration of glycolic acid peels less than 30% can be applied by people other than physicians or providers. Over 30% needs to have provided or applied by medical personnel. Also with these peels, they're safe for all Fitzpatrick skin types from 1 to 6. Their mechanism of action is that they interfere with enzymes that lead to breaking away of the skin, so they have a mechanical metabolic action, and they're anti-aging as compared to retinoids, where they just strip or release the upper tissue for an improved presentation. Glycolic acid is a natural skin exfoliant known as alpha hydroxy acid, or AHA, derived from sugar beets and easily soluble and improved circulation by removal and also removal of extracellular fluid. The next alpha hydroxy acid is lactic acid, other than glycolic acid, derived from or extracted from milk. So if they have a lactic acid intolerance, this may not be suitable for them. It's an excellent humectant and is able to absorb fluids, attracts the skin water, existing molecules to the skin, and stimulates growth of new collagen and elastin. Over the period of time, the skin appears to begin younger and look younger looking. When treating with alpha hydroxy acid, remember we talked about acidity, strengths, concentrations, and levels of care. When treating patients also, you need to progress from a lower concentration to a higher concentration. So you may start at 10 or 20% Glycolic acid would bring its pH somewhere between 2.5 to 4. 30% is a cutoff. That's the maximum level that a non-medical personnel can use for any alpha hydroxy peel. Its pH is somewhere between 3 and 3.5. Above 30, 40, 50, and 60% are medical grade peels, and you need to be aware of the treatment, the neutralization of the product, and the removal before you attempt these high grade peels. Any extension on the surface with these peels without naturalization and neutralization will cause scarring. The peels cost about $40 each. An average price of a peel, as we talked about, is between $75 and $150, comparable to microdermabrasions. Investment for these treatments is nominal. All you have to do is take the course and learn how to do them. And the number of treatments are variable. They can be done serially over a period of time, every 6 to 12 weeks. When consultation for a peel occurs, you need to have a patient's general health history. It's contraindicated in pregnancy, all peels, anything that can be absorbed in the body. So, okay, as a general consideration for patient consultation, you need to be aware of the patient's general history and health. Pregnancy is an absolute contraindication for this procedure, and in my opinion, almost any other aesthetic medical procedure in general, to avoid any potential problem to the gestation. But pregnancy only lasts 39 weeks, and there's no reason why the patient can't wait until the expectation date is over to continue their aesthetic care. I need to do an analysis of the skin to identify problems that can be addressed with peels, including telangiectasias, hyperpigmentations, skin laxities, allergies and sensitivities, rosacea, blood vessels, etc. And you want to be aware of, in their general health, any pre-existing conditions that may come at risk because of these treatments. Obviously, alpha hydroxy acid peels are nominal exposure, but there's some medical conditions that may be exacerbated because of these treatments. Okay, talking about precautions associated with these peels, we're going to talk about possible, relative, and absolute contraindications. Verruga, facial verruga, would be a relative contraindication. Prior reaction to microdermabrasions and peels is also a relative contraindication. Anybody that has herpes simplex virus, HSV1, or cold sores would be relative, unless the patient's on their antiviral medication, and HIV immunosuppressed patients are absolutely contraindicated. People who have exposure to the sun or sunburns in the recent past, anybody who's a keloid former, pregnancy, as we mentioned earlier, is an absolute contraindication. Any surgery within the past 6 weeks on the areas to be treated, and special considerations given to Fitzpatrick scores 6, 5s, and 6s. And Accutane. Accutane is oral tretinoin, and it basically has a predisposition to complications when taken and used with light energies and peels and microdermabrasions. So availability and knowledge of patients taking Accutane within 6 months of treatments, topical treatments, are absolute contraindications. The procedures and protocols associated with alpha hydroxy acid peels. We'll talk about this briefly now. Basically, you want to start off with a cleanser as an optional treatment before any peels. These typically can be done by the estheticians in the office. You might want to use a skin lightener, Retin-A topical peel, for the darker skins to make sure that there's no interruption in the patient's skin tone and skin color. They should be aware that they should not have any sunburn or suntan before the procedures, so SPF 30 or higher before the treatment. 1 week prior to the peel, they should stop any additional treatments at home, including masks, waxing, straightening, perms, lotions, etc. To make sure that the skin comes in as natural as possible. If they have HSV1, herpes virus above the umbilicus, they should start their antiviral medications. The good news to that is that they know what their medications are, and they know how to take them with potential exposure. They take it when they're going to the beach in the summer, going on cruises, or any potential treatments or activity that may expose them to sunlight and cause a breakout. And they want to come to the office completely cleansed, no topicals, no perfumes, no lotions, no creams, no sprays. Basically, what I like them to do is wash their face with an antibacterial soap like HebaCleanse 2 times before they come in, and not apply anything after that. When we're starting with a 30% peel, which is in the 3.5 to 4% pH range, you apply them in quadrants until the patient feels tingling in the quadrants of 5. 1, 2, 3, 1, 2, 3, 4, 5. 5 quadrants. And when the patient feels the tingling, you neutralize it with a bicarbonate, sodium bicarb, or baking soda. And in any event, the peel should not be left on for over 30 minutes. You need to neutralize it before that. If the patient comes in with darker skin types, you might want to try a test peel. Test peels and test treatments are always done on the same tissue that's going to be treated, but not in an obvious location. So if you're testing for the face, you might want to do it on the side of the face, maybe below or behind the ear. That's going to give you the same skin tone, texture, and configuration. So the results of the test spot will be equal to what you're going to be getting when you do a peel. Obviously, no sunbathing mentioned before, and all peels need to be neutralized. All alpha hydroxy peels need to be neutralized, including the test spots. So if you're doing a test patch, don't forget about it. If you don't think there's any irritation, left alone can cause damage. As we mentioned earlier, you may want to start your treatments at a lower concentration, 20%. Some physicians and some estheticians start at concentrations of 10%. The lower concentrations should be applied and considered when you're doing the darker Fitzpatrick skin types, 4, 5s, and 6s. Applied in the same way, neutralized in the same way. Test patches are done as well if necessary, and they should be evaluated at 2 weeks. Test patches for Fitzpatrick's type 1 through 3 at 1 week. And you can also put some topical peel to lighten the skin prior, but that's an optional treatment, and they should be neutralized, including test patches. The goal is to be able the acid to react in concentrations up to 50% or higher. The highest alpha hydroxy peel is 70%, and that's the equivalent to a deep or media level peel of trichloroacetic acid. And it's to insult the skin, clearance of pigmentation, increase in stimulation of collagen, and over a period of time in maintenance, you're going to get improvement of the skin by wounding the papillary dermis and stimulating collagen formation at that level. Let me make a comment on this slide that's very important. Getting above 30%, which is the cutoff between medical and non-medical treatments, increases the potential for damage to the skin, and treating a patient at 70% concentration may give you just seconds between the time of a good peel and a problem or a scar. So my recommendation is, as you're going up the ladder, to make sure you're confident in the treatment area before you proceed, because these peels require experience, and without that experience, you may have a potential of scarring somebody's face, which will be a malpractice suit. That's just something to be aware of. I have a dermatology friend of mine who says that he doesn't do more than 50%, and he does 50% very carefully. So that told me that I don't even want to be in his area. He's a dermatologist practicing as long as I am, and if he has question marks and is cautious with 50% peels or greater, then I'm sure that's not a neighborhood I want to be in. That's just a little bit of advice that I might let you have. In summary, post-procedure instructions to include: don't apply any skincare products, makeups, or anything that would be irritating to the skin for 3 hours after the peel. My typical recommendation is not to apply anything for the afternoon of the day after the peel, and go back to your regular regimen after that. If they have to have makeup or cover up or some type of application, ask them to use mineral-based makeups. They're not irritating and won't exaggerate or enhance the erythema associated with the procedure. Don't add on any alpha hydroxy acid products after the peel, and avoid sunlight at all costs. And you want to avoid any topical peels that may increase or stimulate the area that increases the erythema. The evening of the peel, just common sense, gently cleanse and wipe and dry your skin. No abrasives, no loofah brushes, no loofah sponges, and use mild moisturizers as needed for the first 24 hours or so. Use a gentle cleanser. They make alpha hydroxy acid cleansers that don't contain alpha hydroxy acid but can be recommended by the provider. Apply any topical applications, medications, and sunscreen as advised by the provider. Makeup, if desired, mineral-based, and just use common sense. Don't go out in the sun. Don't brush or highly irritate the skin. Don't put any products on the skin that may cause irritation. Cleanse it gently, and within 24 to 48 hours, it should be fine. There are combination packages associated with these peels. As we mentioned earlier, you can have a alpha hydroxy acid peel in the 30 to 50% range. They're sold in packages of 6. As a matter of fact, microdermabrasions and peels and combination packages are typically sold in packages where you might sell 5 treatments at regular cost and give an extra treatment and no charge. You might also have include in your treatment home use products and included in the pricing, so it's a guaranteed enhanced sale. And they can be used for all Fitzpatrick skin types, but do test patches on Fitzpatrick's 4, 5s, and 6. Remember the upscaling of the Fitzpatrick using the Lance's scaling system, where Asians, Native Americans, Mediterraneans, Mideasterners all have or should be considered 1 Fitzpatrick skin type higher or minimal of a Fitzpatrick 5. And the cost of these treatments, AHA and microdermabrasion, are about $125 to $175 per treatment, depending on the area. So you're talking about combined treatments, maybe double that price. Another class of superficial to mid-level peels are the beta-hydroxy acid. The most common beta-hydroxy acid peel is salicylic acid, made from sodium phenylate, and has a direct relationship to phenol, which is a more caustic peel, not used for large areas, and is used for topical peeling, and has a high affinity for lipids, and a keratinic effect makes it very, very helpful for use for acne. And we'll talk about that as we go forward. So salicylic acid peels are a number 1 or one of the primary beta-hydroxy acid peels, and it is not used on patient who has a sensitivity to salicylates, and can be used on all skin types 1 to 6, all Fitzpatrick skin types. And it can be used in other areas of the body where acne may be present, such as acne vulgaris. Protocols for salicylic acid peels, specifically when targeting acne, is used only for comedonal acne or the non-inflammatory acne. Those are acne grades 1 to 3. Protocols or application and tint testing is the same as for other superficial peels. The peel is applied outside the menstrual cycle because of the sensitivity, hormonal change, and blood circulation effect. Microdermabrasion should not be used when treating patients for acne. It would tend to irritate and stimulate the process, and don't treat more than 1 area or equivalent in lower percentages. Other treatments can consist of combination peels. The V-peel is a combination of a trichloroacidic acid, retinoic acid, salicylic acid peel. It contains phenol, absorbic acid, which is vitamin C, benzoyl peroxide, which is an astringent, kojic acid, and cortisone. Has it all. These typical treatments are proprietary. They are provided by the company, all-inclusive. No other products are necessary for the treatment. A Jesner peel is a combination peel that contains lactic acid, salicylic acid, and resorcinol, and it comes in 3 percentages. They have a Jesner light peel as well as a Jesner's and an ultra, which is a stronger. As we mentioned, combines an alpha hydroxy, lactic acid, beta hydroxy superficial peel, salicylate, and a resorcinol, which is a deeper mid-level peel of caustic acid. Treatment protocols are the same as all alpha hydroxy acid peels and does not require occlusive dressing after the treatment. You also need to make the patients be aware that these higher depth peels cause desquamation more than exfoliation. It's peeling of the skin like after a sunburn, and they should not pick these edges but trim them with a scissor. Picking may cause scarring or permanent scarring in the area. Resorcinol is the mid-level peel or the caustic acid in Jesner's peel. It's a toxic acid used in certain chemical peels. It's very much like phenol in its properties, has a protein poison effect. There are cardiac and renal and hepatic toxicities when absorbed, and care should be taken when using all phenolic acids. They can have the tendency or potential for scarring, and if absorbed, have systemic effects. Although resorcinol in Jesner's peels and in V peels, very, very low concentrations, and it's considered safe. A modified Jesner's peel is lactic acid, salicylic acid, alpha and beta hydroxy acid peels with citric acid. Comes in 2 percentages, a modified light and a modified Jesner's. As we mentioned, alpha hydroxy, beta hydroxy, and a milder caustic acid, which is the citric acid. Protocol is exactly the same, no chains, no occlusive dressing. Remember to avoid scarring. A lactic acid and glycolic bright peel is a combination of lactic and glycolic acid with hydroquinone. Hydroquinone is a defined skin lightener, comes in 2 strengths. A lightener is to reduce the appearance of pigmentation. So if patients come in with a significant amount of hyperpigmented spots like lentigines, sunspots, and age spots, this will be an ideal peel for them. Not only will it correct other skin problems, but it'll have a focus on removing hyperpigmentation of the skin. Protocols are the same, used as maintenance of people who have significant hyperpigmentation or potential for hyperpigmentation, and they have newer formulations coming out that have kojic acid instead. You should be aware that all the literature, protocols, consents, directions, and advertising materials are available to you through Empire. Make sure you get in touch with Empire if you're a member, and they'll send you the portal with the ID to get into the website, plus the password. Also should be aware, as an Empire member, you're entitled to a standard operating procedure manual, which has more than the portal has. It has everything you need to provide the treatments that are taught in the aesthetic field, including certifications, credentialing, chart forms, consents, everything you need for all of the treatments, not just facial aesthetics. Here are some results of superficial peels before and afters. These will be either alpha or beta hydroxy peels. This is a superficial medium peel baseline, and after 12 months with maintenance, remember they're done every 4 to 6 weeks apart, and then after that, maintenance 6 to 12 weeks apart. This is at a 1-year anniversary, and you can see the significant improvement, the reduction of hyperpigmentation, the clearing of the skin, tightening of certain areas, and a more tight, fresh-looking skin. Given in higher concentrations for more significant presentations, like this young lady who had vascular problems, hyperpigmentation problems, and mild laxity problems, a 40% alpha hydroxy peel gives that excellent result. And you can see the reductions of rhytids on the forehead and around the eyes. Here's another example of an alpha hydroxy chemical peel at higher concentration, again addressed for more damage and problems, including rhytids, pigmentation, and vascular changes. Doesn't say the number of treatments, but you can see the dramatic result. This is another high potential cleansing of the skin, clearing of pigmentation, and tightening of rhytids. This is a salicylic peel, and as we mentioned earlier, salicylic peels, beta hydroxy peels are excellent for acne, and look at the relief of the acne in this patient. Although this would be maybe a category or a class 1-2 burdens, she has complete elimination of a process with a 30% salicylic acid peel 3 times over several weeks. The next level of peel is the caustic acid or the medium and deeper peels. They attack deeper structures in the cutaneous area and has an increased risk of systemic effect, as well as an increased risk of local damage to the skin. These peels reach the papillary and sometimes the upper reticular dermis, and because of that, should be used with caution. And because of the depth of the peel, the response is more dramatic, and they're given basically every 4 to 6 months. Also treats other medical problems such as actinic keratosis, which is a precancerous condition, and solar lentigines, which is hyperpigmentation. And you can see the difference in the medium depth peels. They go down to about 0.5 millimeters, and they can be either applied as a trichloroacetic acid at 35 to 50% or phenol at 33% concentration. The role of caustic acid peels, typically caustic acids are trichloroacetic acid, and that's preferred over phenol. The molecular structure is similar to glycolic acid, much stronger than alpha hydroxy acid peels, and typically, like alpha hydroxy peels, do not have a general toxicity, not transported in blood vessels, so there's no systemic effect. Phenol or phenolic peels are weak acids and have a high pKa concentrations. It's up to you to decide which of the medium depth peels you're going to use based on the choice and based on presentation. Trichloroacetic acid is lipolyzed, and physician mixes the contents, also liable for the results. Basically, TCA cannot be neutralized exogenously, and it uses the oils in the skin to naturally neutralize it. Bad reactions have been reported in as much as 25%. 15% is on the low sides, and there's a large amount of treatment, of pre-treatment modalities you need to be aware of before you apply the product to avoid any secondary problems. Risks are evident, and the potential for severe problems as a result of these treatments based on experience and knowledge of the peels has caused many manufacturers to eliminate it from their product line. Alternative to tricyclicidic acid peels is the V-peel. And as we mentioned earlier, the V-peel has tricarboxylic acid, tretinoic acid, salicylic acid, phenol, vitamin A, and other mineral blends. Has same dramatic results without any of the pain, and decrease or eliminates any potential problems and adverse reactions associated with it. Much safer percentage than the TCA peel by itself. Physicians still able to purchase it for a nominal amount of $200. Charges for these type of peels can go up to $400 to $500. No adverse effects since it's self-neutralizing, and the percentages of the ingredients are such to a point where it eliminates any significant or lasting effect. Comes in two strengths, Precision and Precision Plus. Here's some examples of a V-peel. For melasma, remember melasma is considered hormonal hyperpigmentation. You're going to have diffuse hyperpigmentation from UV damage as seen on the right. Can be used in all Fitzpatrick skin types for more radiant skin, and Fitzpatrick's 1 to 6 testing does not have to be used. Here's another example of a V-peel and the limited amount of downtime. Remember, when you get into the moderate level to moderate to deep peels, they will cause not an exfoliating effect but a desquamation effect. So remember not to pick or pull at the wound edges, number one. And the exfoliation or the desquamation typically mimics that of a sunburn. If anybody's ever had a peeling sunburn in the past, typically the first day it burns, the second day it itches, and the third day it starts to desquamate off. And that's the typical sensation you see with these peels. The mechanism of action for the typical or traditional TCA peel is a destructive activity as a consequence of its acidity, and it progresses through the layers of the skin, leading to a coagulation of the protein and cooking of the skin and clearing of frosting aging and skin desquamation. In summary, TCA peels require a significant amount of pre-treatment application. Usually there's a pre-treatment application with tretinoin and hydroquinone. Photoaging types 1 to 2, mild to moderate disease, we talked about that. Fitzpatrick skin types up to 6 need to have a moisturizer applied to the skin immediately after and 4 hours after the skin. Sunblock is required on all skin, 30 SPF for post-treatment. Avoid direct sunlight for 6 to 8 weeks afterwards, and this will go into the deep levels of the reticular dermis. Aquaphor, which is a aloe application used 3 times a day, will decrease the loss of water and the secondary complications associated with it. And reepithelialization appears at the 3rd day, which is at the time you have desquamation of the skin. You need to trim the skin with scissors rather than picking. If the skin burns, itches, or starts to have problems, the typical treatment, and this is a sunburn treatment as well, is to put a tablespoon of 2 of white vinegar in a pint of warm water and wet the skin down with that product, and it eliminates pain, itching in the area. If erythema should persist over time, you can put medium-grade corticotopical steroids like Westcott and Denosidide cream. Precautions for the TCA peel are exactly the same as alpha-hydroxy superficial peels and beta-hydroxy peels, which include herpes simplex virus, previous allergies, history of sun allergies, keloid formations, pregnancy is absolute, Accutane within 6 months, previous surgeries, and high Fitzpatrick skin types. Typical protocols for application preparing TCA peels include step 1, priming of the skin, pre-treatment with topical agents within days to weeks before, starting at least 7 days before, and that includes cleansing and lightening if needed. You might want to start the patient on a AHA cleanser to cleanse the skin, and you can do that twice a week to do a topical home peel, a skin lightener, and a superficial topical peel like Retin-A for the darker skin types. Sunscreen always before. You don't want to apply these TCA peels to sunscreen or sunburned skin. And 1 week prior to the peel, stop all cleansers and topical treatments such as waxings, masks, perms, and exfoliation treatments. Step 2 is to degrease the skin, wash with alcohol, and have or apply a TCA pre-peel to the skin. This will prepare the skin for the TCA application. This can be moderately or mildly painful, so a benzocaine, lidocaine, tetracaine topical anesthetic at 28 and 8 can be applied for a minimum of 15 minutes per quadrant, and use an ascorbic acid wipe to clean the skin prior to application. Preparing the TCA peel, basically the TCA is received as 100% concentration, and to make a 50% peel, you'll mix 1 part purified water and 1 part TCA. To make a 25% peel, you'll use that 50% and dilute it again in half, all the way down to 12 and lower. Variations in the 50 to 12% can be added or subtracted by using mortar. And a 25% peel is a medium peel, whereas a 12% will give you a lighter lunchtime peel. Application should be, the face should be free of all oils and moisture. Apply the solution in quadrants. Suggestion is to use a moisturizer in the area. Don't allow the product to enter the eyes or the mouth for damage to the mucosa. The endpoint is forcing of the skin, and look for excessive erythema. If you're doing a higher concentration and peel, apply stages of divided 20 and 15. Aquaphor afterward to neutralize the peel and to moisturize the skin. Here is the progression of a TCA peel, which is a mid-level peel to deep level peel, forces the skin to desquamate. You'll have redness the first day, a little bit of icterus or itching the second day, and you'll start desquamating the 3rd and 4th day, just like a sunburn. That typically is finished after the 5th to 6th day, and by the 14th day you have an overall improved appearance that only continues to progress. Here's a result of a TCA peel after 1 treatment. Although the time frames are not there, you can see the relaxation and eradication of hyperpigmentation, hypervascular lesions, and reductions of superficial rhytids. To avoid complications, always do a attached spot. Remember, we need to do it on the face with the same type of skin, but off of the front by the side, under or behind the ears. Use the least potent agent for the presentation and complaints. Take photos and a consent on all patients. Educate the patients and let them know the potential risk of the treatment. Let them know about the expectations. Advise skin pickers that they can't pick at any wound edges. People who smoke, use alcohol to excess, or illicit drugs are people who have delayed healing, and that should be taken into consideration. And basically, you need to warn them of all complications associated with commercial peels. And we talked about earlier the complications associated with treatment of patients with aggressive peels and inappropriate care. Here are some secondary problems associated with aggressive peels that were not handled correctly, including secondary infections and scarring. Here's some scarring on the face, neck, and around the eyes with inappropriate peels, a TCA peel that was left on too long, a dorsum of the hands as well, scarring. This was done by a non-physician. Remember, work within your limits and your legal requirements. Any concentration of an alpha hydroxy peel over 30% should be performed by a plenary qualified licensed provider. This is a scarring associated with a commercial peel of the face, and these are combination peels. This stuff never goes away. Can't even be repaired using a skin graft. The lower left identifies a proper placement for a test patch. Remember, we talked about side of the face, behind or under the ear. And here are some complications in the upper slides associated with post-treatment infections. This is hypertrophic scarring of the chest after a TCA peel performed by an esthetician. A TCA peel is a mid-level to deep peel and should only be performed by a provider. In an unexperienced hands can give you complications like this. This young lady will have those scars forever. All peels should have before and after photographs to identify to the patients the improvements after the treatment. It should be done over a series. You know, when people see themselves in the mirror every day, they're typically not aware of the subtle changes that occur because of treatments. You've been on diets, I'm sure, lost several pounds, can't see it in the mirror, become a little bit upset of all the work you've done. And then a few days later, you see a friend that you haven't seen for months, and the first words out of their mouth are, gee, you're looking good. Have you lost some weight? Well, this is the same mentality as why you need to take serial pictures so that you can show the patients of the dramatic improvements associated with your treatment. And here's one example. Here's a collagen remodeling with an alpha hydroxy peel over long-term use with maintenance. Another long-term use with maintenance for an alpha hydroxy peel. You can see the dramatic results, including reduction of wrinkles, elimination of hyperpigmentations, and hypervascular lesions. Another long-term use in a young lady with mild to moderate presentation. Now, this young lady has a little bit more advanced presentation. You can see on her left, I would call her a easily moderate presentation, maybe moderate to early severe, but it shows the significant hyperpigmentation. You can see the difference in the tonicities on the side and front of her face associated with moderate amount of rhytid formations in the forehead and the pericanthal area, the crow's feet, with volume deficits in nasolabial fold and marionette area. And this is a long-term use of collagen remodeling using an alpha hydroxy peel. We don't know what the concentration is, but with the initial series and the maintenance treatments and dosage, you can see this excellent result. This is for acne peel, a beta hydroxy peel, typically a salicylic acid peel. This is mild presentation of acne, but you can see the dramatic improvement, as well as this young gentleman. Now, this acne is an acne 5, Burton's 5, but with a beta hydroxy peel, it's eliminated and made it as mild and highly acceptable results. So as our final item in the aesthetic program, let's talk a little bit about cosmeceuticals. There's a lot that you need to know about this, since it is an additive or an additional profit center for your practice, and there has a lot that goes into it that you need to be aware of. So basically, many claims are made about nutraceuticals and cosmeceuticals that are offered into your practice. The one point I want you to be aware of is that none of these cosmeceutical companies have any magic bullets that separate them from one to another. They all use the same ingredients. They just mix them in different proportions to get to an endpoint that they feel is more realistic to their patients for care than other companies. And they all use the same ingredients, so that nothing separates them, except one company called Skin Medica has a proprietary stem cell formula that they use, but again, that has not any significant differentiation with the rest of the product line. When you're deciding on purchasing a product line to put in your spa, that product line should have components in it that require a physician prescription for dispensing or physician-only line. The products are used so that parts of the line require a physician prescription, separates you from other spas and salons in your area that don't carry or are not able to provide or perform prescription dosing as well. Another point I want to bring up with skincare lines that has to do with choosing your product line is you need to be aware that many, if not all, of these product lines require you to have an initial investment, sometimes thousands of dollars. Obagi used to have a $5,000 minimum purchase for you to bring their product into your spa for sale. Now, what that does is gives you the ability to sell Obagi, but what it also does is put $5,000 on your shelf until you do. What you may not be aware of is that Obagi sells to other vendors, and you can purchase a product that you paid $250 for. You can purchase that same product online for $295 when your wholesale price is going to be $495. So getting this stuff in the spa and on the shelf by putting out money is something that you have to look at. Many providers and distributors are getting wise to the fact, and medical spa operators are shying away from those that require high upfront costs. So you want to look for somebody that minimizes it to somewhere between $1,000 and $1,500, and many of them do comply with that. Getting back to prescription-only cosmeceuticals, it does differentiate you between your practice and other businesses in your area, and you want to carry a skin line that addresses all skin types and all topical skin problems. When they're coming into your office, they're looking for your advice. So basically what you want to do is you want to give them products that get them the result they're looking for. That's the most important point going forward. And each one should have a uniquely tailored package to their problem, even if it's post-laser treatments. And nobody should leave your spa without a cosmeceutical or product package to address any treatment or any problem that they've come in to have treated. You should carry at least 2 product lines in your spa. One should be a medical grade, physician grade as we talked about, and the other one should be a mid-shelf grade that's available in any other retail outlet. Our 2 lines in our spas used to be Skin Medica and La Roche-Posay, very acceptable, well-recognized, effective treatment, not medical grade, but popular and sold very well. These should also address all skin types, can be compatible with all problems and procedures, and nobody leaves your office without a package containing cosmeceuticals to address their problems or treatments. In general, most spas will treat or have their employees treated at wholesale prices, and they can also make a commission on their sales and make sure we have physician-only treatments. Use of these products, this slide brings out an important point that you might not be aware of as a new entering aesthetic physician. What would you do if somebody came into your spa and said, Doc, I've been abusing my skin most of my life. Do you have any skincare instructions that I might use on a daily basis that'll help improve and protect my skin? Well, if you sit there telling them nothing, he's not going to have great appreciation of your knowledge and skills as an aesthetic physician. So this slide tells you exactly what you need to tell them. Every person who is looking for good average daily skincare for protection and improvement should first cleanse their skin and then apply an exfoliant to take off any loose dead skin that's about to come off. So you're going to get a cleanser to take off all the grease and grime, an exfoliant to get off all the topical layers of skin that are going to be coming off anyway that day. At this point, what you're going to be doing is you're going to be treating or toning. And the third step, if you have a problem, let's say acne, that requires placement of benzyl alcohol or an astringent, something to cleanse the skin, this is where you would do it. Then you would moisturize and then protect. Those are the 5 treatments for good skin care, and these are what your home products should address. There are hundreds of products out there. The best cosmeceuticals are the ones that have the best marketing analysis, the ones that you see on television that people ask for. There are some products, and we talked about Skin Medica, that has stem cell formulations that help to increase result. Brand name recognition is most important. Watch out for the buy-ins. We talked about that. They can be expensive, and they can put money on your shelf that you could use for other etiologies. And you want to make sure that the sales and marketing is up to stuff. Remember, physician only. Thank you very much for your presentation, and that's the end of our facial aesthetic program for today.